So good afternoon, Mr. Chairman. I hope you can hear me. It sounds to be a great invasion coming through the door, so we are delighted to have you all here and for this session. And I'm very glad to be being invited by the organizers to cover such an interesting topic. Now, since my lecture is the first in that row, I thought I may start off with some general remarks regarding diagnosis of endometriosis. Now, we are all aware that we are dealing with a disease which is actually defined as growth of endometrial tissue outside the uterus, and this location can be in several sites, and it's regarded as a benign condition. It's often unspecific what the symptoms are regarded, so we have to see how that relates to diagnosis. And apart from causing pain, in several studies have been shown that there is a high percentage of overlap between patients having endometriosis and them being infertile. Now, one major problem is the delay of diagnosis, and that's why I think it's most appropriate that we are dealing with this problem today. I have listed for you a number of studies showing that basically in many countries it takes many years until we find a diagnosis in patients who are suffering from that disease. And I think just looking at this slide is a sufficient justification to rethink our way how we diagnose this disease. The first issue I'd like to point out is that there are a number of theories on the pathogenesis. And obviously, if you are using theories, it means you don't know what the pathogenesis is exactly, because you need several theories to cover the entire field. Now, to make a long story short, the first one, being the transplantation theory, is generally regarded as a major one, which we need today to understand some of the aspects of the disease. Now, this implantation or transplantation theory covers the idea that you have in almost all women retrograde menstruation, and once this shedded tissue is coming through the tubes, it will adhere to the peritoneum, as you can see here, and it depends on the condition what these tissue will find. It may implant, proliferate, and invade that tissue. Now, it appears that it depends on the tissue itself how this will grow. So patients who seem to have endometriosis appear to have different endometrium from women who don't. So that's an important thing to think about, because that would mean that you would have a kind of a tool to look at the endometrium in order to understand which of the women may actually get endometriosis. Important for diagnosis. Now, in some women, this will not go on, but it will regress, and scarring tissue will occur. But in others, this will proliferate and grow and maybe even disseminate. The main issue is that these different steps will cover different type of endometriosis. So when you look at them at the laparoscopy, you will see different colors and different types of these tissue. So you may find all kind of different ways how to look at this disease. Now, obviously there will be a number of regulatory mechanisms why in some women this disease will develop and in others won't. If all women have retrograde menstruation, obviously there is a number of genetic, endocrine, immunological, mechanic, etc. ways that in some women these tissue will grow cause pain, and maybe infertility. Now, there are an incredibly growing number of publications to understand what pathogenic mechanisms we could use to look at the disease and use it potentially for diagnosis, but also for therapy. And I just grouped the different publications by their area. So for many years, immunological aspects have been looked at, and a huge number of publications came out to look at the different immunological cells and fluid within the peritoneum. It appears that not just immunological aspects of the peritoneum, but also aberrant cell proliferation, all kinds of enzymes, this MMP is an enzyme involvement, etc., will be involved to regulate the disease. Important aspects are also resistance to progesterone, which is one of the hallmarks of the disease, which means that if you use that agent, you may actually end up not having a proper activity. The tissue, once it grows beyond 1 millimeter size, it will require additional angiogenic activity, meaning they have to get access to the tissue as well as to all kinds of vessels in order to grow further on. Now, one of the aspects which seems to be extremely important is whether stem cells, which react quite differently to all kinds of therapies, will be actually the reason that in some patients you will not have sufficient effect with the treatments we have today. And in order to use expressions of RNA types, which are called microRNAs, we have now a potential way to understand how these pathogenic mechanisms will occur. And I think I may have some time in my second lecture in the debate to elucidate further details on that. So to just briefly summarize up to now, we have major challenges to attack, and this is relating one to etiological questions because it's quite unclear, and pathogenesis just as well. And it appears that there may be several entities, as you know, the location itself, but also the type of tissue you get may depend where they are, like peritoneum, the ovary, or the deep infiltrating nodules, which is quite a difficult entity. So we'll actually have a debate on that aspect later on. So in order to cover for you the diagnostic ways, I just listed the ones which are obviously used today, just as for many other diseases. And I'd like to go through a number of those, not all of them, because imaging will be later on a topic, so I will just make it quite short. Now, the first one is risk factors. Now, if we don't diagnose the disease early on, that means it takes quite a while to understand how the symptoms will relate to a potential disease. So, as you can see from here, women who have certain type of symptoms have higher risk or lesser risk than women who don't develop endometriosis. So you can see, just as we all know, dysmenorrhea obviously has a high ratio that's about 8-fold risk that women who have dysmenorrhea will have eventually going to be diagnosed of endometriosis. But also, if you take history, if you list some of those issues which may have occurred to these patients, you can see from those that even other potentially what you think are unrelated diseases may actually increase the risk of these women having the disease. It doesn't necessarily mean that these symptoms or these problems actually cause endometriosis, but they are linked to an increased disease. Now, next point are the symptoms. Now, a whole bunch of symptoms were listed in a big study in patients who have been diagnosed by histologically having endometriosis. So women are actually having a whole lot of symptoms, as you know, so it's quite difficult just going by symptoms to be sure whether this patient will actually have the disease or not. So we do have a limitation here already, and we have to know that women often go first to non-specialist doctors, and they may not have that access to invasive procedures. Now, next one is, how can you diagnose the disease if you even think about it, and if you think that the patient may have that disease? You can actually do, obviously, a vaginal examination, and in one of those studies, it has been shown that in the deep tissues, deep invasive parts, it's quite a big range how specific and sensitive vaginal examination is. To make it clear, I think in most hands, vaginal examination is not an extremely good diagnostic procedure, especially if rectal exam is not combined. So vaginal examinations often is a difficult method to diagnose the disease. Even in specialists, and this is a publication written up by a specialist, even there some of the locations are difficult to being diagnosed by vaginal exam. Now, if you can't palpate it nowadays, you take the ultrasound. And in some cases, as you can see here, you can assume that tissues which look a little different than the normal tissue next to it will be potentially an area of endometriosis. Since young women normally don't have other serious diseases, it's quite common that if you find that you have a high likelihood that it could be endometriosis, but it's uncertain because it's not so specific. And even if you look at different other sites, and we'll have later on a lecture on imaging, it's not so easy to demonstrate whether it's really endometriosis or not. And these are the cases being found to have endometriosis later on. So it all depends where the location is if you use ultrasound. And if you obviously have a endometrioma, which is easy to diagnose by ultrasound, but others may be more difficult. And if you take, for example, deep invasive lesions, in some cases you have an extremely low sensitivity. So imaging has a problem here, just as here as well with vaginal ultrasound, even in more experienced hands. The same actually is quite limited for rectal ultrasound, and you have to understand that these studies have been performed by people who are quite experienced. So in some cases you have a rather low sensitivity, even on rectal ultrasound. So what are the problems? The problems are not just being unable to diagnose a disease by symptoms and vaginal exam and ultrasound, but even on invasive diagnosis, which is regarded as the gold standard. So I thought maybe I'd just go briefly about this problem, because diagnosis is even limited at that point. So when the easiest thing, which you can see by ultrasound, is operated, being chocolate cysts, in this study it has been shown that quite a number of percentage is incorrect, and 3 different publications have shown that. So even in the case where we think it's quite simple. Now when we look at peritoneal endometriosis, one can decide whether the patient has endometriosis visually or histologically. And as you can see from that, there is not a huge overlap. In some cases, cases doctors thought, well, this is endometriosis, but histologically it wasn't. In 1/3 it was both, and in these cases was negative. But here again, biopsying lesions and place where you thought there was none, even there you can find it. So you have a great problem even on laparoscopy. So we think due to that problem, one aspect is to actually to have histological verification, even though this is also limited because obviously pathologists don't necessarily look at an endometriosis case with the same accuracy, I think, than, let's say, with malignant disease. But also we have a problem when surgeons look at it. So in some cases, if there are no biopsies done or they are done in a different place. So I thought I show you a study one of my co-workers has performed, asking 98 gynecological surgeons to tell in 3 different categories what they think about the site of the disease, how many sites, etc. So 3 different cases were taken. In one case, no endometriosis was actually there. Then low grade and a somewhat higher grade of endometriosis. And as you can see here, from that, in a way, blinded study, the doctors didn't know, and they were shown these films and pictures, and you can see how wide the distribution is, even taking laparoscopy. So I think there is a kind of limitation, even to the gold standard laparoscopy. Now that's not entirely surprising, because what I told you is when pathogenetic steps occur, you have all kinds of different tissue, and they may appear bluish black, or just black, or adhesions, or very active red lesions, more white lesions, etc. So just taking these 5 different ones, you may have all kinds of implants, and you have to decide about their importance. And that's exactly the problem. You can't really exactly tell what's the exact activity of individual implants using the techniques we have today. So you have all kind of variation on location, type of growth, etc. There are some methods in order to be conclusive on that, to try to help and to use immunofluorescence, and in some cases we do use that. And sometimes you can actually sort of light up, make these implants light up as it's shown here, to make it even more simple. But it's obviously a bit more tedious to do that. So finally, ladies and gentlemen, I think we have a whole range of methodology to understand and also diagnose endometriosis. But as I have shown to you, we have limitations almost in all issues I have raised today. So just looking at the very first slide I've shown to you, that the delay of diagnosis is tremendous, is already one. But even if you suspect it, you will have a problem to find that out. So it's difficult to say, is this disease important? What's the prognosis? How it will affect? And maybe later on in the debate we can get a few more details how we can actually go about that in future. So I think we'll have a long way ahead to get more diagnostic procedures to understand that disease. Thank you very much.